Good morning. Today in the procedural scale, I am going in the procedural skill. I am going to speak on appendicectomy. By definition, removal of appendix is known as appendicectomy. There are various indications for doing appendicectomy. The first and foremost, acute appendicitis, then recurrent appendicitis as a interval appendicectomy after drainage of abscess or an appendiceal mass after a interval of 4 to 6 weeks. In cases of carcinoid tumors, mucocele of the appendix as a pentacular graft or a ileal conduit or on-table colonic lavage. For all these procedures, appendicectomy appendicectomy can be performed by two ways, either open technique or laparoscopically. Before subjecting the patient for appendicectomy, various investigations are to be performed. The main investigation is urine analysis to exclude the pus in urine, full blood count, ultrasound scan to know the diameter of this appendix. For surgery, rehydrate the patient with IV fluids, pass catheter if required, put a nasogastric tube. If there is vomiting present, then IV antibiotic prophylaxis is just before the surgery. It can be performed under general anesthesia if it is performed laparoscopically, and if it is performed in uh, by open technique, spine is can be performed under spine. The position, patient is placed in supine position, painting and draping done. Skin preparation is done from the nipple line to the mid thigh. There are various incisions that can be given for performing the appendicectomy. The most preferred is the McBurney's position, McBurney's incision or gridiron incision. In this incision, it is placed perpendicular to the McBurney's point. The McBurney's point is a point which is drawn from a line, imaginary line taken from the anterior spine up to the umbilicus, and from the medial two-third and at the junction of medial two-third and the lateral one-third, this perpendicular incision is given. The other preferred incisions are Lange incision. It is cosmetically better. It is skin crease incision. It is approximately 2 cm below the umbilicus, centered on the mid-clavicular midinguinal line. The other incisions are Rutherford Morrison, where this McBurney's incision, McBurney's is converted into muscle cutting. Then it can be performed by the lower midline, right paramedian, or there are various other approaches. This diagram shows the various incisions that are given, and in the red line is the most commonly preferred incision, which is known as McBurney's incision or the gridiron incision. It is given at a junction of medial two-third and the lateral one-third from the anterior spine up to the umbilical region. The various steps are: the classic transverse incision can be made with two-thirds of the incision lateral to the McBurney's point. Alternatively, the point of maximal tenderness or the location of the appendix based on preoperative imaging can be used to determine the location of the incision. The procedure: the scalpel is used to incise the epidermis and the dermis, dissect the external oblique aponeurosis by scissors or the cautery. The aponeurosis is opened in a supralateral to the infromedial direction along the direction of its fibers to expose the internal oblique muscle. The internal oblique muscle is bluntly divided perpendicular to the direction of its fibers using the long artery forceps and thrusting inside. The transverse abdominis muscle is similarly divided and the peritoneum is active. The peritoneum is grasped with forceps and incision with a 15 number blade. Now attention is now focused on locating the appendix. The best way to locate the appendix is, if you are able to visualize the cecum, it can be used as a guide to help identify the appendix. Else, follow the tinea coli where it terminates, and the point where this tinea coli, three tinea coli terminate, that is the base of the appendix. Use the Babcock's forceps to grasp the tinea coli and advance until the appendix is externalized. Alternatively, a finger can be swept around the cecum, beginning supralaterally and continuing inframedially to locate the appendix. Once identified, the mesoappendix is dissected and the appendiceal vessels are divided between clamps and ligated with silk sutures. It is supplied, appendix supplied with the appendicular artery, which is a branch of iliopolic, a branch of the supramesenteric artery. Then, after identifying the base of the appendix is is thrust in between the two artery forceps and it is transfixed within the bicuspid 20 sutures. Then the peritoneum is grasped with curved Kelly's clamps and approximated with cerebrocontinuous absorbable sutures. The transversus and the internal oblique muscle layers are irrigated and loosely approximated with loosely absorbable sutures. The external oblique fascia is repaired with continuous 20 round body bicuspid suture. The subcutaneous tissue is irrigated and the skin is approximated with staplers. If there has been extensive contamination of the wound, it should be left open and the subcutaneous tissue packed with saline soaked gauze. A delayed primary closure can be done. In the post-operative management, in uncomplicated cases, root fluid is started 12 hours after recovery, followed by light diet 24 hours later. In complicated IV fluid, IV antibiotics and L-Parolol with nasogastric tube drainage until bowel activity recommences and temperature subsides. Stitches are removed usually in 7 to 10